So I think what it feels like to have OCD, it's a little bit like walking around with a gun pressed to your temple all day long. So if you can think about if you had a gun pressed up here and nobody else can see the gun, but you know the gun's there and you can feel the gun and you can hear the person holding the gun whispering to you, you better do what I say. If you don't do what I say, you know what's going to happen. You're going to get hurt. Somebody in your family's going to get hurt. You've got to do this. There's no choice. And so all day long, you sort of walk around with this feeling like your heart is up in your throat because when you're having an active OCD episode, you're really in the fight or flight response because your brain does not know the difference between an actual danger and the danger that's been created in your mind. And so you're incredibly frightened all day long. And you're doing these compulsions to reduce the anxiety. And so it just feels incredibly frightening and exhausting because you can't stop doing these compulsions because anybody being, held up with a gun would do exactly what the gunman is saying. And that's the way people with OCD feel, is we just do what the OCD is saying because we don't want to take the risk that if we don't, the gun's going to go off.
Yeah. I was going to say, it sounds painful.
It's exceptionally painful. In fact, OCD, of any mental or medical condition that anybody can get, it's the 10th most disabling condition in the world.
Mm-hmm. 10th most disabling in the world.
In the world.
Well, and you mentioned something at the very beginning, medication, that they had given you medication. Mm-hmm. And as a clinician, it's always been my understanding that OCD is treatable with medication. And so in my head, if I ever see these symptoms, I'm thinking, first go to a psychiatrist and then go to you. That's my second thought. But is medication effective with this disorder?
So yes, it can be. And the way that we optimally want to use medication is in combination with exposure therapy. That's why we want to combine the two.
And when you say maintenance exposure, I'm thinking of, people who have social phobia. A clinician may do exposure therapy by taking you out in the public. If you're fearful of flying, you may have a task to get on a plane and be exposed to that fear. But you're talking about, I'm going to expose the thoughts, and then I'm not going to let you do your compulsion. I'm going to let you sit with that thought, and even with the gun to your head, you're going to find out that there's no gun to your head. It's okay if you just sit with this thought. It is not going to hurt you. Mm-hmm. So the exposure for OCD is really the thought and sitting and not doing the anxiety alleviating behaviors or rituals that may relieve that symptom. Is that accurate?
It's a little bit more complicated than that. Yeah. So the types of exposure, the technical names is in vivo exposure. So that's actually going out in life and doing the things that OCD doesn't want you to do. And then there's imaginal exposure or scripting, which is imagining scenarios that your OCD doesn't want you to imagine or creating things that you can't actually go out and create in real life. And the best way to do it is to have in vivo. You need to be, for ERP to be maximally effective, you need to be acting as if what the OCD says is irrelevant. And so you need to go out in your life and do the things that OCD's been telling you that you need to avoid. We use imaginal exposure when we can't create the situations in real life, or when people are having trouble stopping mental rituals, because people who are primary mental ritualizers are so good at it that they can do it while they're doing almost anything else, and some of it's exceptionally subtle, and we've got to stop all that. So we'll use imaginal exposure. We'll teach them different things to say out loud to interrupt the cycle of compulsions, because if somebody's going out in life and approaching the things they used to avoid, but they're up in their head doing rituals, we're actually strengthening the OCD. So it's a matter of designing exposures that help people go do the things they value in life while stopping the rituals, which can be quite subtle. But if we do this over and over and over again, that's how people get better.
It is a lot more complicated. It's a lot more complicated. And the other complication is the idea that some people in our community also use the idea of OCD and basically saying the gaming is obsessive. Mm-hmm. The drinking's obsessive. Mm-hmm. So how do you speak to that? Because that is difficult for even a clinician. I know a lot of parents think they're just obsessed with this and it's OCD and they can't stop thinking about it. So help me understand how you would explain that to the community. Gaming obsessions or addictions.
Yeah, and I think that term is fine. I mean, people can have obsessions with things that they find pleasurable. But the difference is that an obsession in OCD is nothing that anyone would want to have. Obsessions, when it comes to OCD, are disturbing. They're highly, they're what we call ego dystonic, meaning that they are against the concept of self that the client has. So you'll often find people with OCD are really nice people. It's one of the reasons I love working with them. They're so nice, and they have these exceptionally violent thoughts. And those violent thoughts are ego dystonic in that they're totally against the way they are. And I think that's one of the ways that OCD gets you stuck. If being a kind person is something that is important to you, and yet you're having these thoughts of stabbing your parents in your head every day, that causes a lot of distress. So the types of obsessions that people with OCD have are nothing that anyone would want. Whereas obsessions with something pleasurable, like video gaming or other, the internet or other things, like a girlfriend, yeah, that's not OCD. If the obsession is something that you like, that's just an obsession. If the obsession is causing distress and you want to do something to neutralize the obsession, well, then that's looking more like OCD.
I think that's fascinating because I think there's a lot of crosshairs in this. A lot of people just get these mixed up and confused and call it different things. So even clients, patients, when they call in to get an intake, they're already saying what the diagnosis is, and you've dispelled some of the ideas already just in this small little video. The hard question I had for you, and I was driving over here and I was like, I have to ask her this one, is I'm a faith-based practice. And I know a lot of people come in and they can get very ritualistic around their prayer life or the rosary beads or confession. And yet I wouldn't want to tell anyone to stop reading the Bible. I mean, that would be contrary to my belief system. So how would you treat somebody with a religious OCD, a ritual? Yeah, how would you treat that?
And so that's really common, and it can be called religious OCD. It can be called scrupulosity is another word for it. And the way that we do this is we never want to do anything that is against someone's spiritual practices. But the other thing we need to do is with scrupulosity, what OCD has done is here's the religion, and OCD has wrapped itself around the religion like vines, like a kudzu vine, right? So it's just all entwined in it. And so really what happens is the person is, instead of actually praying, what they're doing is they're treating OCD as God, and they're doing what OCD wants them to do. And what sometimes we have to do is, like if somebody is doing praying rituals, is we will ask them to stop praying temporarily so we can pull the vine off of their religion, out of their spirituality, so that when they go back to praying, they're praying because of their religion and their faith. They're not acting like OCD is God and doing what OCD wants them to do, repeating the prayers over and over, saying it in a certain way, all that kind of stuff. So we will work carefully with somebody to pull OCD out of religious practices. And sometimes that means that we sort of almost like ask God's permission, like, gosh, we're just not going to pray for a little while, and we're just going to hope that's okay. Sometimes, though, with scrupulosity, it's about disappointing God. And so people are doing things because they think I'm disappointing God. And so we work with them. And sometimes, if it's helpful, we can bring in their religious leader to help them understand it's okay not to do this, and we're not going to do this particular practice, and we're going to sit with the uncertainty that maybe you are disappointing God and you won't know. So it's a very, it works very well, and it's just very subtle, and we just have to work so that everybody is comfortable being uncomfortable, and we're not actually doing anything that violates any religious traditions. But sometimes we may have to stop some traditions for a while, again, so we can unwrap that kudzu vine, so we can put it back in someone's life in a way that they can actually be there with God.
I love that. OCD being their God, and that just shifted it for me so that I could even be able to be comfortable with how to treat that, because that would be a huge problem. So I love how you describe that. That's helpful. One of the things that I liked about what you offer in our community that I didn't know until I sent a referral to you was that you do sometimes work with families and educate families on how to love someone with OCD, and you're educating them as well. Do you still do that?
Yeah, that's a standard part of my practice because OCD is incredibly disruptive when it comes to families. And families will get involved in the compulsive rituals. It's called accommodation. And the more families provide accommodation, the harder it's going to be for somebody to get over the OCD because it's like rituals by proxy.
Give me an example.
So somebody doesn't want to do their laundry because the laundry has been at school and they don't think school is disgusting. So, parents do the laundry. They're afraid to answer the phone for some reason, so they never have to answer the phone. Family members answer the phone for them.
Okay.
So a lot of times this is helping people avoid the things that are just going to trigger the OCD.
Mm-hmm.
Sometimes it is just getting involved with the rituals. Sometimes you'll see this a lot with kids. The kids want to come home and confess everything they think they might have done wrong at school.
Yes.
And then parents go, "That's okay, honey, you didn't do anything wrong." And that's just reinforcing the OCD. So it's really important that OCD includes the family, anybody who lives with the person or is in close contact with that person, because otherwise the person can be trying to get better, but their family members might be reinforcing the OCD. Because typically the things you do as a parent, for instance, saying, "Honey, that's okay, you didn't do anything wrong," that's actually going to make the OCD worse. But the parent might not know that otherwise.
Yeah. And how would a parent respond in that situation so that it would be healthy? Because, that's just a knee-jerk parent response to be like, "That's not true, don't worry about it," disproving it. But what would be a healthy response even in that situation?
And so this is what's really important is we work on this as a group in therapy. So we work on it with the parents, the child, and me, or whoever the family member is and the client, so that we all agree when you want to come and confess, mom and dad are just going to get up and leave. They're not going to listen to you confess. And if you ask me if it's okay, then mom and dad is going to say, "I don't know, maybe," and walk off. But you have to set that up so that everybody understands that's what's going to happen, because if parents have been accommodating and then they just rip accommodations away, that can actually make the client worse.
Right.
So setting these up front and having these expectations and having the client agree, yes, this is going to be hard, but I'm not going to confess, and if I try to confess, get up and walk away.
Right.
That means the client is invested in the process. We're not doing it to the client, but the client is saying, "Please help me by doing this."
Mm-hmm. They're aware of the response they're going to get. They're going to be aware of the uncomfortable feelings they're going to have to sit with. And it is so, I would think as a parent, it would be just as uncomfortable to try to walk away from that and not want to soothe them. But you're right, if they're walking into a situation where they're making their loved one more sick, they'll walk away and find a new healthy pattern for that child. It's amazing, what you've just talked about. I can think of 3 or 4 families. I'm like, "Oh, I hope this family watches the video so they get a little bit more information." So I was out in the lobby, and I know I've seen your book. Can you want to talk about your book? Or
Sure.
Yeah, tell them about your book.
So, Is Fred in the Refrigerator, Taming OCD and Reclaiming My Life is actually...
How did you come up with that title?
Well, it's a story in the book.
Okay.
So one of my obsessions is Fred in the Refrigerator, and I won't tell you who Fred is because that...
Now I have to get the book.
But I used to obsess that Fred was in the refrigerator. I had OCD for so long untreated, probably close to 35 years untreated. And so I've had almost every variety. So the book is really my story of living with untreated OCD as a child and a young person, getting diagnosed, but sort of bouncing around and getting told to do everything but exposure therapy, and my OCD spiraling out of control. And then finding exposure therapy, learning how to do it, going back to school and becoming a therapist and becoming an advocate for other people. It takes on average 14 to 17 years from the time that symptoms start for somebody with OCD to get the right treatment. And if you think about that, that's more than a decade of hell, really.
That's too long.
And so my my goal is to try to do everything I can as an advocate and a therapist to try to reduce that time, because I know personally what it's like to suffer with this, and I would like people to get treatment, the right treatment, a lot faster than I did.